Continuing with the compact echo course, we will discuss the peristernal short and also to a certain degree the peristernal long axis view, how to use Doppler, for example, pulsed wave or continuous wave Doppler, and certain M-mode measurements we already started to talk about in the prior video. So, talking about Doppler. For Doppler, we have to have an optimally aligned signal. So we have to have an optimal image, because if the image is out of plane or the image quality is reduced, Doppler signals won't be optimal, and that can influence, of course, the measurements. As mentioned, we will talk about the pulsed wave, the PW Doppler, and the continuous wave Doppler, the CW Doppler. With pulsed wave Doppler, you have a sample volume, so you measure in a certain area the velocities, and normally you measure lower velocities. With the continuous wave Doppler, you measure the velocities all over a certain line, where you can measure higher velocities and you do not have a distinct sample volume. The same holds true for M-mode measurements. In M-mode measurements, the image quality has to be very good because you measure a certain line over time. So also the M-mode has to be aligned optimally. You have a very high temporal resolution, but you do only scan one specific anatomical area, which is also the limitation of M-mode measurements. For you to make it easier probably is the anatomical M-mode. This is a version of the M-mode where you can align the M-mode not from the transducer beam, but from different positions in the image. M-mode might be an old measurement, but in some pathologies it is still useful and gives you a lot of additional information. Well, we start again with the peristernal short axis with the level of the aortic valve. We remember we have the aortic valve in the center of the image, here the tricuspid, here the pulmonic valve. And when we focus on the aortic valve, we have seen this patient already in the previous video. We do see that this is the aortic valve in the center with this thickened cusps. And here we have this central and mild aortic regurgitation. When we use M-mode, we see that this resembles the opening and the closing of the aortic valve. This is the M-mode and the so-called aortic box. So this is diastole and this is systole. We do see that there is a certain degree of premature closure of the aortic valve and it doesn't open entirely. But we do see if we add color information to this, here is the opening of the aortic valve and this is the closure. So this is diastole, this is aortic regurgitation. It is holodiastolic, so it's throughout the entire diastole, but it's definitely not severe as it is just this small line seen in this color M-mode example. Furthermore, when we focus on the aortic valve, we do see very often sclerosis or calcifications. They can range from mild to really severely calcified valves. Also in this case, M-mode can be to a certain degree useful. If you use M-mode through the aortic valve again, seen over here, you do see that there is an opening still present, but the cusps, they are thickened. But the aortic box is preserved, so we do see this cannot be severe aortic stenosis. These are examples of severe aortic stenosis. You see that it looks entirely different. It's very hard to differentiate the diastolic part from the systolic part, and here you see the severely reduced opening of the cusps of the aortic valve. So the aortic box is very small. Also, you can add color M-mode, color Doppler information. This is a small pulmonic regurgitation. So this is the RV, the RVOT. This is the left atrium. And here we have turbulent flow. Also here turbulent flow showing aortic stenosis. Of course, you cannot quantify aortic stenosis, but it will give you already information of what's ahead of you if you perform certain measurements. This is another example where you have a severely reduced opening and a regurgitation as well. Moving on to the tricuspid valve, we already mentioned that you can use color Doppler to display the tricuspid valve and tricuspid regurgitation, as in this case. You can use continuous wave Doppler. This is a different example, a different patient now. This is by far not an optimal signal. there is just trivial tricuspid regurgitation present, but we do see that the velocity never reaches 2.5 meters per second. But this is a huge pitfall. Always aim for an optimal signal, as for example in this case. Here we have the tricuspid regurgitation of a patient with amyloidosis. You do see it's definitely not just trivial, but here we have a really nice jet and a nice alignment of the continuous wave Doppler. And we do see that here the signal ends just around 3 meters, 3.1 meters per second. So this is resembling pulmonary hypertension. So a continuous wave Doppler signal above 2.8 meters per second. The same you can do in the peristernal long axis view, where you can see the tricuspid regurgitation here in an atypical view of the peristernal long axis. If you do not know how to perform these atypical views, click the box and watch the video on the atypical views of the peristernal long axis. Also here, if you look at the alignment of the color Doppler jet with the probably moderate tricuspid regurgitation, you do see that here we get a very nice signal, again reaching almost or approximately 3 meters per second. This is another example of measuring tricuspid regurgitation, also reaching approximately 3 meters, but you see that there is a problem with the tricuspid valve overall. This patient received a tricuspid clipping. So the tricuspid valve was clipped due to a massive or a torrential tricuspid regurgitation. Now we still see regurgitation, but it's definitely not massive, or at least it's not torrential. So there's a reduction in the grade of tricuspid regurgitation because of this clipping of the tricuspid valve. A very important pitfall is that the jet has to be aligned optimally to perform continuous wave Doppler measurements. In this case, you see that's the tricuspid valve and the jet is a little bit eccentric. So with the continuous wave Doppler in this alignment, which would be seen like this, you can never measure the true peak velocity because you are not aligned properly. And this is also resembled in these signals. This is definitely not a good signal for the tricuspid valve. So in these cases, we have to try other views. We have to rotate the transducer, tilt the transducer, turn the transducer, probably have to go to peristernal long axis or apical views. Optimally, you can measure tricuspid regurgitation, of course, in the apical views to get an optimal signal. Just keep it in mind wherever you measure tricuspid regurgitation that the signal quality has to be optimal. This is an example where you see tricuspid regurgitation over here. It's also a little bit of an eccentric jet, but because the alignment is optimal, we can measure here the tricuspid peak velocity is above 4 meters per second. So this is definitely a signal which resembles pulmonary hypertension. So if there is optimal alignment, you can even measure eccentric jets.